Hello, folks. What we're going to be talking about today is obtaining vital signs. And I set this screen up where the vital signs are off to the right for a reason, because it's common for people to want to zero in on obtaining vital signs on their first contact with the patient, when in fact, vital signs are not the first thing we should get, particularly in pre-hospital emergency medicine. When you go to a doctor's office, you tend to be seated in the waiting room, or rather in the exam room, and the first thing that happens is sometimes the nurse will talk to you, and sometimes they'll get vital signs first, or sometimes they'll do both at the same time. For us, however, we go through a slightly different process, and the initiation of patient care will be assessing certain qualities before we move on to vital signs. So that's why I put it on the far right of the screen, because actually there's a number of observances we're going to make about our patient's general state before we even get to vital signs. And what's interesting about vital signs is if you do your assessment well, your vital signs are just going to corroborate what you've already found to be true on assessment. So, for example, if I have a patient that I note is not responding appropriately, and their skin is pale and cool and moist, they seem a little bit agitated, and they're complaining of dizziness, I'm going to expect that their heart rate is probably elevated, their blood pressure is probably slightly within normal limits, but perhaps a little bit lower than I would expect to find. I will also expect that their respiratory rate might be slightly elevated, and their pupils will probably be somewhat dilated. And if they're complaining of a respiratory difficulty, then I will also expect their respiratory rate to be affected and their pulse oximetry, the SpO2, to be affected. And in all likelihood, the vital signs will be exactly what I project, because I've already assessed my patient, and the vital signs are going to confirm what I've found on assessment. So when we consider our patient and assessing our patient, before we get to vital signs, we're going to think about how we naturally appear to our patient and how we are naturally going to interact with that patient. So when we first walk up to them, we note their level of consciousness. Now, LOC is sometimes referred to loss of consciousness, but we'll consider whether or not they are alert, which is A on this scale, responsive to verbal stimuli, responsive to painful stimuli, or unresponsive. So just on walking up to them, we can often ascertain what their level of responsiveness is. So really, that is the first thing we tend to assess on our patient, far before we get to vital signs. The next consideration is generally going to be we may form a general impression at this point in our assessment, just from walking up to them, talking to them, and looking to see how they appear. So it's entirely possible that just those first few seconds of interacting with the patient, we may form a general impression just from looking at them. And then the next thing that we're going to be looking at, long before we look at vital signs, is airway, breathing, and circulation. However, the order might be reversed to circulation, airway, and breathing. So the question will be, how do we know which one to assess first? So if you walk up to your patient and they look at you, they make eye contact with you, you determine that they're alert, then we can go ahead and move forward with assessing airway first, and then breathing next, and then circulation next. But if we walk up to our patient and they appear to be unresponsive, then the first thing we're going to do is check circulation, which means we're going to look for the presence of a pulse. We don't want to rate. We just want the presence. So again, we don't want the pulse rate here. We just want to know the presence. Is it there or is it not there? If it's not there, no pulse, I bet you can imagine what we'll do next. We'll go to CPR. If it is there, yes, pulse, then we assess airway next. So we walk up to our patient, we note that they're alert and they're talking to us, then we've already assessed that they have an airway because they're alert and they're talking to us. Are they talking normally? Do they sound short of breath? Do they have any strange sounds? If none of those is true, then they are breathing. And then we check for a pulse. We know that they're going to have a pulse because they're talking to us. So basically, we just want to know present, yes, we know that's true. So is it fast? Is it slow? Is it weak? Is it strong? That's all we want to know. If we have an airway, if we have breathing, and we move on to a pulse check, we simply want to know, is it fast or slow? And is it weak or strong? These steps here are part of the initial assessment, which will fall under the umbrella of the primary assessment, which the terminology of these assessments aren't so important right now, but they will be later on in the course. Just suffice it to say that when you first walk up to your patient, you're going to, again, just to repeat, we're going to walk up to the patient, and I want you to kind of imagine the scenario that you've been called for a motor vehicle crash, your patient is a restrained driver, he's still in his seat, and so you're walking up to the car and you're going to be looking through the window at the car or at the patient in the car probably 10 to 15 feet before you even get there. You've already made sure the scene is safe, and we'll take that out of the equation. You, of course, have your body substance isolation on. And as you're walking towards the car, you're going to be looking at your patient and you're looking to see, does it appear that he's awake or not? And if he is awake, does it look like he's trying to make eye contact with you? That's going to determine the level of consciousness, the level of responsiveness, and then how alert are they? Are they alert, meaning they make eye contact with you appropriately, or at least they're looking around at their surroundings? Are they only responsive to verbal stimuli, meaning you have to talk to them to get them to respond? Are they only responsive to painful stimuli, meaning you have to press on a nail bed or perhaps do a sternal rub? And then are they unresponsive? If they're unresponsive, that's immediately going to determine that I have a poor general impression. And in fact, if my patient is anything other than alert, that's going to cause me to have a negative general impression for my patient, which means I'm going to start considering that they are a significantly injured or ill patient, and that's going to step up my process a little bit. So all this I've done just as I walk over to the car. Now, if they're alert, then I know they have an airway, they're breathing, and they have a pulse. Nonetheless, I want to be sure they have an airway by talking to them. When I talk to them, does it sound like they're breathless or not? If they're breathless, I'll make note of that. Are they breathing adequately or inadequately? So I've erased some of the screen so that we can revisit the breathing piece. So we've walked up to our patient, and if they are talking, then they have an airway. Now, if they're coughing, they have a partially obstructed airway, possibly, but if they're talking, they have an airway. So talking is a good clue that they have an airway. If they are perhaps, like we said, coughing, then we can consider that they're not completely in the green, but they're not in the red either. If they are unable to talk, then they might have lost their airway. The next thing we want to consider is, are they breathing? And if they're breathing, is it going to be adequate or inadequate? So we've already addressed A, and now we're going to move on to breathing. So we want to know, is it adequate? And if it's adequate, how do we know? We know by two things: the rate and the work of breathing, abbreviated WOB. Now, an appropriate rate is generally going to be 12 to 20 in the adult patient. And the work of breathing, there should be no work of breathing, negative work of breathing. What are we talking about when we say work of breathing? We're talking about a person who is using their accessory muscles. So if there is work of breathing, they're going to see positive use of accessory muscles. And when we say accessory muscles, what are we talking about? There's a really long list, and we will get into that more when we talk about respiratory complaints. But I think we've seen people who are tripoding. They're leaning forward, resting their hands or their elbows so that they can lean forward. Or we'll see increased use of chest muscles, or flaring of the nostrils, pursing of the lips, bobbing of the head. All of these things are accessory muscle use. And if you see that, that means they have increased work of breathing. And increased work of breathing is no longer adequate breathing. So if they have a rate that's less than 12 or greater than 36, we start to question. And really, a number better than 12 would be 10. And those numbers are somewhat elastic depending on how our patient is presenting. If we have a patient who's an athlete and they don't appear to have anything wrong with them and their respiratory rate is 8, I'm not going to worry about that. If I have a patient that is obviously excitable and scared and nervous because something just happened that frightened them and their respiratory is greater than 36, but I don't see use of accessory muscles, I'm not going to worry about that either. All right, so these numbers are somewhat elastic. What's really going to give credibility to the numbers is whether or not they have increased work of breathing. That's the really compelling piece. Okay, so now let's move on to circulation for a moment. I'm going to erase this screen as well. So when we talk about circulation, we're going to be talking about the presence of pulse or pulselessness. And then we're also going to be talking about the presence of bleeding. That's what we're assessing when we look for a circulation check in our patient. Now, if we know that our patient has an airway and is breathing, then we know they're going to have a pulse. So if we see, and how are we going to know that they have an airway and breathing and therefore have a pulse? If we walk up to them and they're alert, we know that they must have a pulse, because you can't be alert without having a pulse. Whether or not they have a patent airway, patent meaning open, that can only be determined by talking to them. But generally, if they're alert, they're certainly breathing. They might have an airway that's somewhat compromised, but usually we're going to see them coughing or making some kind of hand signals that indicate they're having a rough time. But as long as they're alert, they have a pulse. So if they're not alert then the first check is going to be to look for the presence of a pulse. So in our unresponsive patient, we're going to first do a pulse check, But actually, we can do this pulse check while we assess their airway and their breathing. It's kind of like these flow charts that we see ask us to do things in a linear fashion, when in fact we tend to be looking, listening, and feeling for everything all at the same time. So if I have a patient that's unresponsive and they walk up to, or I walk up to them, then I might lean over, look, listen, and feel for the presence of breathing as I obtain a pulse all at the same time. And that will be in my unresponsive patient. So actually, technically, in an unresponsive patient, we look for pulselessness first. Now, like I said, I'm going to be doing all at the same time because I can get a pulse while I lean over, look for the presence of chest rise in my patient. However, in people who are pulseless, they also tend to have a color change where their skin will often have a grayish kind of cast to it if they're pulseless, or they might appear to be somewhat mottled, and that can be signs of pulselessness. And then, of course, the absence of a pulse itself will indicate that they are pulseless. The other circulation issue is bleeding. So if we walk up to our patient and we see blood gushing from a wound, and they're just squirting blood everywhere, then what we do first is we don't even worry about airway or breathing, even if they're unresponsive. We immediately address the circulation issue. So the order of airway, breathing, and circulation, or circulation, airway, and breathing, those assessments are going to depend on how our patient appears when we very first see them. Do they appear pulseless? Then we're going to do a pulse check first. Do they appear to be bleeding? Then we're going to stop the bleeding first. Then we'll do airway, breathing, circulation. Okay, so all of this, again, falls under the initial assessment. We haven't even talked about vital signs yet. Now, granted, this whole assessment, this initial piece, is going to take about 30 seconds to a minute. The amount of time I'm spending talking about it is eons longer than this process is actually going to be. You're not going to be able to do it that quickly for a while. It's probably going to take you a good minute, minute and a half just to assess all of this when you first start learning how to do this. But once you get quick about it and once you learn, you'll make this whole assessment, this initial assessment, will take maybe 15 seconds, something like that. Then, depending on what is going on with your patient, you're going to continue your assessment, obtaining and gathering information from your patients. So let's address that, and you'll see that we have another piece before we still get to our vital signs. So I'm going to erase the screen again and pause for a second. So we've established our patient's level of consciousness. We've identified whether or not they have any airway, breathing, or circulation issues right at the start, or circulation, airway, and breathing issues. And we formed a general impression. And all of that is going to take place in roughly the first 15-30 seconds of our interacting with our patient. Then we're going to determine what their chief complaint is, which is not necessarily the same as what the dispatch information is. It's basically, why did they call 911 today? And then from there, we're going to gather all this information, sample, OP, Q, or ST. The first letter is for signs and symptoms. Signs are something we can see, some symptoms are something our patient experiences. And we're going to ask them to give us an idea of what they're experiencing today. And we can go into further depth with that later. The next is, do they have any allergies? And this is going to include allergies to seasonal allergies, allergies to foods, allergies to medications. Then we want to know if they're taking any medications. And that includes over-the-counter medications, herbal remedies, and the like. Because believe it or not, your diet, herbal remedies, and prescription medications and over-the-counter medications can all interact with each other and render other medications less or too effective. Then we want to know previous or pertinent medical history. So again, H-axis history. Again, we don't need to know about them getting their tonsils out 40 years ago if their chief complaint is chest pain today. L is last oral intake. So what did they have to eat or drink recently? And E is events leading up to the illness or the injury. Now, the next thing that we'll assess, OPQRST, is going to be assessed not just for pain, but also for any sign or symptom that is an abnormal sign or symptom. Not all of this is going to apply, but you'll see. First of all, we want to know what the onset of the difficulty was. What was the onset of the chest pain? What was the onset of the dizziness? What were they doing when the nausea and the vomiting occurred? Does anything provoke or palliate this symptom? So, if they're dizzy, does walking around the room make it worse or provoke it? And does laying down make it better or palliate it? Now, what is the quality? Quality refers more often to pain than anything else, but we can still assess it. If there's any pain, we can ask them, is it sharp? Is it dull? Is it crushing? Is it tearing? Tearing is a big one. Does it radiate? Does it move from one point to another in the body? So these two are specific to pain. The others in OPQRST can describe any other symptom they're having. S is severity, and that's going to be on a scale of 1 to 10. 10 is the worst ever, and 1 is very little. And then time. How much time has elapsed since these symptoms began? So we still haven't obtained vital signs yet. This piece, this oral interview, this verbal interview with your patient or with your patient's family members is going to be hugely important, and we haven't even gotten to vitals yet. So we're going to pause here, and then we will resume with actual vital signs. Okay, so we have reviewed that we're going to start our patient assessment, looking down here, and we're going to start with an inspection of our patient's level of consciousness, and that's going to be as we approach our patient. We're going to form a general impression, if we can, early. And then by the time we actually reach our patient, we're going to consider assessing their airway, breathing, and circulation, unless we suspect they have a circulation issue, either they're pulseless or bleeding, and then we'll assess their circulation and then their airway and their breathing. Now, if at any point any of these 3 ABCs is an issue, we stop what we're doing with that issue and we don't proceed with checking the others until we've rectified the first. So, for example, if we come up to our patient and we see that their eyes are open, but they're making a gesture like they're choking, and we see that they are not passing any air and they do not have a patent airway, we don't check anything else until we've assisted them in getting a patent airway. Maybe that's doing abdominal thrusts. If we find they have a patent airway but they're breathing inadequately, we don't move on to assessing pulses until we address the fact that they're not breathing adequately, which would mean that we assist their breathing, we assist their respirations with a bag valve mask operation, with a bag valve mask. If we note that they have a circulation issue, we walk up to them, they appear mottled, they appear to be bleeding. The mottled color appearance makes us believe they're pulseless, and we assess that they're pulseless, then we don't worry about airway. We immediately begin CPR and then we can think about airway and breathing. All right, so it's important that we remember that order because that's of huge importance. All right, so we have gone through those steps. Then we've assessed our patient's signs and symptoms, their allergies, whether or not they're taking medications, their previous medical history, last oral intake, and the events leading up to whatever made them call 911. And that's, of course, after we have figured out what their chief complaint is. Why did they call 911 today? And then we can assess their pain or any other abnormal sign or symptom by asking questions regarding OPQRST. Now again, the quality and the radiation, those two tend to pertain specifically to pain, but all the other part of this mnemonic can be applied to any other difficulty they're experiencing, whether it's dizziness, nausea and vomiting, shortness of breath, and what have you. So now we're moving on to the objective data. So when we look at their heart rate, we're going to obtain a pulse, obviously. First of all, we're going to check for a minimum of 30 seconds. And then we're going to multiply that number by 2. We want to know a rate, and we also want to know the regularity. So what is the rate? And ideally, it should be 60 to 100 for an adult. And we want to find out about the regularity, meaning is it regular or irregular? So we'll put R for regular or I for irregular. And then we'll talk about the strength or weakness. Is it weak? Thready is another word we use to describe that. Strong, or bounding, which is an overly strong pulse. A person with a bounding pulse often will have rising intracranial pressure from a head injury, and often you'll see hypertension that goes with that. The next thing we'll assess is the blood pressure, and that generally the average number for a blood pressure is going to be somewhere in the neighborhood for an adult of 120/80. The big thing to pay attention to for this is that there should be a 30 to 40 point spread between the systolic, which is the top number, and the diastolic, which is the bottom number. And again, if you didn't see it in your textbook, we're measuring the pressure inside the arteries when the heart is contracting for the top number, the systolic. And then we're measuring the pressure in the arteries when the heart is resting in between squeezes. And there's still pressure in those arteries, but it should be 30 to 40 points lower. So if we have two of these numbers that are narrow, closer together, less than 30 points, then that is called a narrowed pulse pressure, and that can be a sign of a person going into shock. There's a number of reasons why a person can have a narrowed pulse pressure. A person that has a widened pulse pressure is usually decompensating. This is what we see as a patient begins to decompensate and starts to die from whatever is putting them into shock to begin with. Generally speaking, also, it's important to remember that a person's blood pressure tends to increase with age, and physical fitness will have a bearing on both the heart rate and the blood pressure. It tends to be lower in physically fit people. And that's both the resting heart rate, I'm not spelling physically fit right, the heart rate and the blood pressure. Now the respiratory rate in our adult patient should be somewhere between 12 and 20. And again, these numbers are elastic. If I see a person with a resting respiratory rate of around 10, or even 8, I'm not going to worry if they don't have any other issues. But not only are we going to look at the rate, we're going to be looking for any signs and symptoms of increased work of breathing. That can be accessory muscle use, where you'll see an exaggerated use of their chest muscles, their abdominal muscles with diaphragmatic breathing. You might see flared nostrils. You might see them leaning forward in a tripod position. They might bob their heads or grunt as they're breathing. That's considered increased work of breathing and use of accessory muscles, and that means the person is not breathing adequately. We also should see an equal chest rise in our patients. So all of that is going to be part of assessing our respiratory rate. And this also should be for a minimum of 30 seconds and multiply that number by 2. When we listen to a person's lung sounds, we'll say this is their front, and here's their clavicle and their sternum. Generally, we're going to put the stethoscope here, mid-clavicular line, and then we're going to compare to the other side. And then we're going to listen right here, right underneath their arm. And that's the mid-axillary line. And then finally, we can listen down here, right at the base of their lungs. And we're always going from one side to the other. One side to the other. We're not going top to bottom because we want to compare like side to the other like side. And generally speaking, it should be negative for sounds, except for the sound of air moving in and out. So if you hear what sounds like air squeezing past something, those are wheezes. If you hear what sounds like hair being rubbed together or tiny little crackling sound, those are called rales. If you hear the sound of a really thick milkshake when you get to the bottom of the milkshake and you suck up through the straw, totally disregarding your mother's guidelines, that thick viscous sound of that milkshake moving through the straw is called bronchi, and that's the sound of mucus in the airways. I'm going to skip BGL, we'll come back to that in a second. Now, as soon as we assess our patient, as soon as we start talking to them, and certainly by the time we've checked for a pulse, back when we looked at airway, breathing, and circulation, we should assess their skin. And ideally, it should be warm and pink and dry. Now, what about persons of color? Sometimes if a person has very dark pigmentation to their skin, it can be difficult to assess that pinkness that tells us that their tissue is being perfused, fed a good amount of blood adequately. So then it would be important to look at their mucous membranes inside the lip, in the conjunctiva or the inner fold of the eye, up at the gums. Anywhere where the skin tends to be more pale, it should be nice and pink there. Generally, it should be warm and it's dry. However, if we find our patient is pale or cool or moist, and these are my abbreviations here, that is a finding of shock. All right, so we're going to assess their skin as well. Temperature is part of assessing the skin, but we're going to do that with a thermometer, and that's considered a vital sign now. And then we're going to use the pulse oximeter, and generally speaking, we're hoping for something greater than 95%, unless it's a chest pain patient, and then we're happy with 95%. 95% is okay. We don't need to bump them up to try and get them higher than that. But generally 95% or greater. So we'll say greater than or equal to 95% is what we're hoping to see as a normal finding. And we addressed the work of breathing already, so I had that in its own category. And so I don't need to address that again. We're also going to be looking for pupils to see if their pupils are equal and round and reactive to light. Generally speaking, if a person is in shock, if they're experiencing fear, if they've got an injury, or if they're very sick, we tend to see their pupils somewhat dilated and a little slow to respond. And that's because they're in the fight or flight response, which for a person to fight or flee from danger, they would need dilated pupils. So we are going to examine their pupils, and we mostly want to see if they're equal and reactive to light. And sometimes you'll see a person whose pupils are two different sizes, and it's important to ask them if that's ever been addressed with them before, because that might be a normal finding, and it is a normal finding in a certain population of persons. My father had that condition, my husband does as well. So we want to ask them, has anyone ever told you that one of your pupils is slightly larger than the other? And if they start to panic, you can just say, I just need to know if this is a new finding. It's normal in a lot of people, so I'm asking you today if you have any knowledge of it. And then the last vital sign we're going to obtain is blood glucose level. This is not something we routinely do on every person, but it is something we should routinely do on people that have altered mental status, AMS. A person with altered mental status is a person who very well may be alert, but they are not oriented, times 4. And when we say oriented times 4, what we're talking about is they know the day, they know who they are, where they are, the day that it is, and they know the events leading up to calling 911. Now, if they don't know all 4 of those, then they are alert and oriented times whatever it is they do know. So if they know who they are and they know where they are, but they have no clue what year it is, and when we ask them what day it is, keep in mind that all of us can forget. Is this Saturday or Sunday? If they don't seem to know which day it is, then let's try the year. And if they don't know the year, that's usually a problem. So if they're familiar with where they are and who they are, but they don't know what happened, and they don't know what year it is, and they are only alert and oriented times 2. But again, they only earn that alert status if they respond appropriately to us without us having to really nag them to get their attention. So generally speaking, when we walk into the room, we'll expect them to make eye contact with us, and we know they're alert. But if their eyes are drifting all over the place, they're not focusing until we really talk to them to get their attention, then they're not alert. They are responsive to verbal stimuli. All right, so I'm going to finish out with my little explanation here and add a couple of videos just to address how to obtain blood pressure, heart rate, and respiratory rate. Well, actually, before I send the videos, I can address a couple of things. When we obtain a person's pulse, we don't want to use our thumb to obtain their pulse because our thumbs actually have an artery that feed them, and we have a thumb pulse, if you will. So we're going to use the pads of our index and our second finger. And generally speaking, you want to palpate for the bone that's on the thumb side, that's the radius, and then you'll feel that bone, and if you slide your fingers inward, you'll feel a little bit of a divot there, and that's usually where you're going to find a radial pulse. You can also find a brachial pulse by taking, again, the same 2 fingers and pressing on the underside of a person's arm right below the armpit area. And in a very lean person, especially in children, if you press against that bone, the humerus, you can often feel a pulse there. You can always consider sliding your finger along the mandible into that groove alongside their trachea, and that is going to be where your carotid pulse is. Now, when you obtain a blood pressure, and you do it by hand using a sphygmomanometer, the numbers that you arrive at are always going to be in even numbers. A machine may find that the numbers are odd numbers, but those dials are calibrated to only denote even numbers. So don't say you have 123/81, okay? So each little hashtag represents 2 millimeters of mercury. And what you're going to do is you're going to put that blood pressure cuff on your patient and read the cuff because it'll say this side to patient, and that'll ensure that you have it facing the right way so that when you go to blow it up, the Velcro will actually stick. And generally, if we know that a systolic of 120 is pretty common, we can pump it up to like about 160, 140, 160 for an adult. For elderly people, we might want to go a little higher in case they have a history of hypertension. Then once we do that, we're going to open up, because we've closed the valve as we pumped it up so the air stays in the cuff. Once we've pumped it up to that desired number, we're going to unscrew that valve a little bit. And this is where people have the hardest time because that fine motor skill can be difficult. You're going to open it up just a little bit, and we're going to watch that needle, and we're also going to listen at the same time. And as the needle starts to move backwards and down, oftentimes we'll see the needle jump right before we hear the first heart sound. So when we hear a pulse in the stethoscope, because we're placing the stethoscope right across the artery in the crook of the arm at the AC, then the first time we hear the heartbeat, that's going to be our systolic pressure. We're going to continue to let the air leak out slowly, and that heartbeat will go away, and that is the diastolic pressure. So again, it takes some practice to get the motor skills more than anything. Respiratory rate, a good way to get that is you can either get the patient's pulse and then continue to watch their chest rise as you act like you're obtaining a pulse, because oftentimes if people know that you're tracking their respiratory rate will just get altered. You can even place your stethoscope on their chest and listen to them breathe if you want. You can place your hand on your chest or on their back to feel for the rise and fall as well. So those are just some helpful hints, and we will definitely be working on these skills quite a bit. So please do not worry if you are worried. And I will see you on Wednesday. Have a great weekend.